Good. I'd like to start by thanking the organisers for inviting me to address the conference, and I wish you every success in your meeting. I've been asked to talk about the use of gallium-67 as a partner in a theranostic pairing, and this is really looking at an agent that's been around for a very long time and trying to give it a new use. And I think I hopefully will be able to show you that it actually has a lot of potential for use in theranostics and will fill a very much needed gap at the moment. The image that you're seeing on the right-hand side of the title slide is, of course, a gallium-67 whole body SPECT CT image, and that's something that we are moving more and more to these days in nuclear medicine. So no longer doing planar whole body assessments, but moving to fully 3D imaging such that the studies that are being done, whether they're bone scans or gallium scans like this, are really very similar to what we get with whole body PET, FDG and other agent studies. So now we're just looking at a totally tomographic approach. Of course, the other thing is that we are increasingly seeing SPECT imaging as being a quantitative discipline, and this will also help to enhance the use of gallium-67 in theranostics. Just to step back for a moment and think about how we treat cancer today. I've tried to capture it in this figure here and show the sort of the domain over which these approaches can be applied. Of course, surgery remains very much the first line of call if we are trying to cure the patient and the patient has limited disease, typically non-metastatic disease, or we are using surgery to address an acute situation such as an obstruction in the bowel or maybe the bronchus. And of course, that means that surgery has a very limited kind of range that we operate over. Going a little bit further, radiotherapy. Radiotherapy can be used at a couple of different sites, although it's not really useful for metastatic disease, but certainly for treating localized disease, perhaps in combination with surgery after the surgery's been done to irradiate the surgical bed, and also to palliate especially bone pain. It can be used in a number of situations. So we're seeing an increased utilisation to different further around the body, going from surgery to radiotherapy. We then have directed regional treatments such as intra-arterial embolization, such as TACE. We've got radiofrequency ablation techniques. We've got topical gels, perhaps in the case of skin lesions. And again, these can be used in a number of different locations, but they are targeted towards a regional type of treatment. Moving on to systemic treatment for metastatic disease, of course, we have classical chemotherapy. And under the medical therapies now, we've got quite a wide range of different approaches. We've got the biologics, the inhibitors. We've got increasingly T-cell therapy, such as CAR T cells. And of course, immunotherapy, which has had such a dramatic impact in a number of metastatic situations. The final one, and this is where we're talking today, of course, is the molecular radionuclide therapy, which is really designed to be used in the metastatic setting. It's where we have widespread disease, and we combine that with imaging to demonstrate that there is a molecular target that we're going to be able to hit with our therapy. And so it really is a very nice combination of some of the best aspects of medical therapy. That is, it's systemic, can be widely applied throughout the body, but it's using radiation. So it's a bit of a mix of the two of these, and we are increasingly using it in a theranostic paradigm where we're going to image the targets first and then follow it with a therapy. Let me start by just setting the scene for what I mean by theranostics. I appreciate some of you may not have encountered this term before. Theranostics is the combination of therapy and diagnostics, and it truly is this combination that we exploit in the new approach to molecular radionuclide therapy. In Theranostics, we have a molecule which is targeted towards some molecular target. In this case, this is an octreotate molecule which is targeted towards somatostatin receptors, which are overexpressed in neuroendocrine tumours in particular, and also some other cancers. And here we have a DOTA chelator. So this is a linker that allows us to then put a radioactive metal, gallium-68 in this example, into the cage created by the DOTA linker, and that's then linked to the octreotate molecule. The idea is that we would image this. This is a positron emitting tracer. Gallium-68 has a 68-minute half-life. The idea would be that we would inject this into the patient, and then after some period of time, allowing for uptake, we would then image the patient to see if we've got uptake at the sites of the disease. If we do demonstrate that, then the next idea is to replace the imaging radionuclide with a therapeutic radionuclide, and this is lutetium-177 made in a reactor. It's got a half-life of just under 7 days. It emits both beta particles, which are what we use for therapy, as well as gammas, which we can use to image to demonstrate the uptake. And so this is the idea of the theranostic. You use the same molecule to demonstrate targeting, and you follow that with the therapy, knowing that it should go to the same sites. Now, when we think about how we approach treatments, I think there are a couple of different levels and with increasing complexity. Many of you will be familiar with treating thyroid cancer or overactive thyroid with radioiodine. And I classify this as a one-size-fits-all type of approach, where we do very little to tailor the treatment to individual patients. So there's little or no patient-specific information in our treatment plan. In our institution, most patients would, after having their thyroid removed, would then have an ablation dose of radioiodine of around 4 gigabecquerels, independent of the size of the patient or how much residual disease we think they have or metastatic disease, and so on. So, I mean, the good side is that it doesn't need any specific developmental work or planning beforehand, and can be applied easily. At the next level we get to, and example here I'm showing is of intraarterial treatment of liver metastases with selective internal radionuclide therapy, or SIRT, using yttrium-90 as the treatment with a beta particle emission. We use a little bit of information about the patient when we develop these plans. For example, we start by adjusting based on height and weight to try and make an allowance for variations in the size of the liver of the patient that we're treating, so that we don't want to give too much radiation that would cause damage to the normal liver parenchyma. But we still don't factor in a terrible amount of information in terms of the amount of disease, the disease burden, and so on. So there's a little bit of work required by the physicists and the clinicians in developing that plan, but it's not very involved. And really, at the other end of the spectrum, I think we're familiar with radiotherapy treatment planning, where this takes hours of painstaking identification of tissues at risk, and then detailing a plan of how to treat the tumour, the lesions, with the minimum amount of damage to the surrounding normal tissues. And this really does take a great amount of effort. There's a lot of imaging involved. There's a lot of time involved from the radiation oncologist through to the physicist to implement the plan, and then to the radiation therapist to deliver it. And so what we really see is an increasing amount of information from very little at one end of the spectrum through to a vast amount needed, and more as we get increasing sophistication. And our theranostic treatments at the moment are still fairly much at this end of the spectrum, where we're not using very much information at all to personalise or tailor this in any significant way. Our patients, such as the one shown here with a metastatic neuroendocrine tumour being treated with lutetium-177 octreotate, is receiving 8 gigabecquerels independent of their size, the disease burden, and so on. We use a standard dose for that. And here's an example of how that's implemented. This is the gallium-68 dotatate PET image showing a primary lesion here in the small bowel. That's the spleen, normal uptake. That's the urinary bladder, that's normal excretion, and there's kidneys sitting in here, but the rest of this is all metastatic disease, predominantly to the liver, but also you can see a little bit there in the abdomen as well, in the lymph nodes. So once we've demonstrated that you have uptake like this, we can then move to treatment, and here are the treatment images. So this is 30 minutes after the infusion of the lutetium-177 dotatate. You can see a lot of blood pool activity, but you can start to see uptake already in the cancer. After a couple of hours, there's been excretion. There's also been further uptake into the lesions. So we're seeing the background decreasing. And the next day, you can see well concentrated in the cancers. And this is at 92 hours or day 4, and you can see that it's still there. So this is the theranostic paradigm today. If you can see it like this, then you can treat it with this. And there are many examples of theranostics that we have available to us today. I've mentioned thyroid cancer, where we can use iodine 123 or the PET iodine 124 to then treat, or I131 to image with, and then we treat with the iodine 131, which is the beta emitter. And there's lots of different options here. You can see MIBGs, dotatate, and as I've just shown you in neuroendocrine tumours. Looking at the SIR-spheres treatment, we do a planning study with microspheres, labelled with technetium, as you would for a lung scan, and then treat with the SIR-spheres. There's been work in the past with antibodies for lymphoma, anti-CD20 treatments. We can look at a bone scan and then treat with radium-223 or Xofigo. And increasingly now we're starting to see gallium-68 PSMA for prostate imaging, followed by lutetium-177 for prostate therapy. So when we're talking about the imaging pair, the partner in the pair of theranostic agents, what are we looking for? Well, I would suggest that these are the ideal properties of an imaging theranostic agent. It needs a half-life that's matched to the biological pharmacokinetics, so typically of a few days. It should have a significant fraction of photon emissions so that we can image it, of course. The photon emissions should be suitable for imaging with either the gamma camera using SPECT or the PET camera, and it should be quantifiable, and that'll allow us to do dosimetry and do better planning. Ideally, there are no particle emissions so that we don't do any damage, significant damage to the cells while we're doing the imaging treatment plan, and so no alphas and no betas. It should have an acceptable radiation dosimetry for a diagnostic investigation. The radiochemical labelling should be readily achieved, and this is, we know, not always true with technetium, but certainly with the radiometals, we're seeing that that's easier to do. There should be a high degree of in vivo radiochemical stability. You don't want the radio label falling off the molecule after a couple of hours in vivo, as you want to follow it over time. It should be readily available. It should be relatively inexpensive, of course, and ideally, if it's got a long enough half-life, you would make it in a central lab and then distribute it to all the sites that need it, so you don't have to reproduce the radiochemistry. So, so what are some of the options? Well, thinking about PET, the first ones that you can exclude, I think, really are fluorine and gallium-68. These are the most commonly used radionuclides in PET imaging, and they are unsuitable, really, for looking at a biological distribution over time. As I've shown you, the gallium-68 image of the dotatate, you can use it to demonstrate uptake, but you can't really do anything more with that in terms of assessing how much dose you will deliver, because you need to follow that over time matched more appropriately to the half-life of the treating partner. So it turns out there really are quite a lot of options that you can use, and I've listed them here. Copper is a very interesting radionuclide, an element. The radioisotopes are multiple, and lots of imaging possibilities there. So copper 64 has a roughly 13-hour half-life, so you can do some longitudinal studies of uptake and distribution changing, and then you can follow that with copper 67 treatment. I'm going to suggest gallium-67 is also a good agent with about a 3-day half-life. Zirconium-89 is used in PET. You potentially could use some technetium, although the half-life is probably a little short compared to most of the treating radionuclides. Indium-111 has been used. Iodine-123 can be used, of course. 124 in PET. 131 can be used, but has the downside that it does have the beta emission as well. And lutetium likewise does give off a fairly low fraction of gammas, but has the downside of the gamma emission, but still, of the beta emission, but still, of course, can be used as a theranostic. And here's an example just showing the use of copper. This is, again, octreotate radiolabeled with a chelator called SAR, so they call it sartate. And this is showing you the uptake at 1 hour, so similar to the previous gallium-68 image that I showed you. And this is a patient with a meningioma. You can see here in the skull the red dot. And then this is at 4 hours because we've got a 13-hour half-life. We can follow this over time. We could never do this with gallium-68. And here we have image the next day. So that really is a nice half-life to be able to follow with whole body imaging and then do some dosimetry estimation. If you're doing gallium-68, of course, you need an on-site chemistry team, like you see here, and all the synthesis modules and things. So there's if we can use a longer half-life tracer, you can get away from needing all of this infrastructure and personnel. And so that's where gallium-67 might have a particular role. So it matches all of the criteria that I showed you in the previous desirable slide attributes. It's got 3 individual gamma rays, around 93 keV, 184 and 300 or so keV. We use this routinely. We've used it for a very long time. If we go back, in fact, gallium-67 for doing measurements of cancer and proliferating tissues. This is an article that was published in Radiology in 1950 after a talk that was given in 1949. So really, we've known about the existence and the potential of gallium-67 for a very long time. We use a lot of gallium in our department in Sydney for infection imaging these days. So it's still commonly in use. And here's an example of radiolabeling of gallium-67 in that sort of biodistribution study that I've been alluding to. This is a monoclonal antibody that's targeted against the GPC1 receptor that's overexpressed in many solid tumours. And again, you can see here, these are planar images. So, we didn't do whole body whole body gallium-67 imaging with SPECT at this stage, but we did planar imaging here. You can see straight after injection a similar distribution with a lot of blood pool remaining, and 5 hours, 24, and so on. This is out to day 7. You can still see we're getting good quality imaging. So with a 78-hour half-life, we still can go for a week or so, and that should be sufficient for most traces studies as a workup for the therapeutic treatment that will follow. And how would you use it? Well, you would inject the individual, you'd take some images at different time points, and with those data, you are then able to fit the uptake and retention or clearance curves. And this is showing you from Olinda entering the percent injected dose that's retained in this tissue. In this case, it's the heart contents. And that is then used to estimate the dosimetry. And from that, we get from the Olinda adult male model, we get an estimate here of the dose to each of the organs and the total body, including the effective dose at the bottom. So that allows us to tailor it to a particular individual. When it comes to radionuclide therapy, what we would tend to do is to take a small cohort of different individuals, usually with the disease that we are interested in, and we would do dosimetry estimates, just as I've shown you with those gallium-67 images, which is what we were doing with those. We would then work out the average individual dosimetry to each of the organs and the effective dose to the whole body. And then we would do a tracer study in an individual based on what we've known and we'd learned from cohort 1. We would then be able to adjust the dose to what we would like to give to the cancers, tissues, but keeping the normal tissue doses acceptable as well. What are the challenges? Well, we still really have to prove that we can do quantitative gallium-67 SPECT CT. Technetium is readily available now as a quantitative SPECT procedure from most of the vendors. Likewise, lutetium-177 because of the interest in dosimetry. Some of the questions are how many photo peaks to image? Do we use all 3 or just 2? Some suggestions are that you might get better image quality with just 2 because you're not including downscattered photons so much from the 3rd peak, and the spatial resolution of the highest peak might be quite poor. Do we need to do them separately, or can we lump them all into a single window? Does each gamma photo peak need its own attenuation map, or can we use an effective map for all 3 or 2 photons combined? The spatial resolution we know is relatively poor with medium energy collimator. Typically, we've measured for lutetium around 20 millimeters full width half maximum or so. Can we improve that? Because we're really going to need to do that to do some good dosimetry on smaller lesions and tissues such as lymph nodes. And we just need to be aware of that we need a global supply of gallium-67. Sometimes that may not be assured. I'm hoping that my colleague here, my future colleague Ajid, is going to take up this challenge, and she's joining me later this year to undertake a PhD in the implementation of gallium-67 in Theranostics. I'm going to just focus at this point just on one of the issues here, the spatial resolution being poor, and I think that's been a major impediment to accurate dosimetry for smaller tissues. And as I mentioned, we see, and we've measured resolution around 20 millimeters full width half maximum for lutetium-177. And as we know, you need an object of 3 or so times the resolution of the system before you start to approach full recovery due to partial volume errors. And so for organs such as the liver and the spleen and the kidneys, I think the dosimetry we've been doing with lutetium-177, say for dotatate or PSMA, is probably fairly accurate. However, I don't think that same is true of lymph nodes and smaller lesions, and I think we're greatly underestimating that. So something we've been working a lot on in our laboratory, and just an example showing you, here's a copper example again, showing you the copper sartate. This is PET scanning, so this is 4 hours, and then these are, again, the sequential images over a couple of the copper-67 therapy out to a few days here. We need to improve the resolution of these studies. This, again, is the patient with the meningioma. You can see the difference in the spatial resolution for the 2 studies. So if we were to make an estimate of the dosimetry to that lesion, I think we would be greatly underestimating the concentration in the lesion and hence the dose that we'd be delivering. Now, we realised that when we were doing this, that we've actually got matched images of PET and SPECT for these studies of copper-64 and copper-67. And this led us to thinking, well, why don't we use these images in some way to try and improve the quality of these images? And so Harry Marquis in our group is a PhD student, and he's implemented this a synergistic, what we call a theranostic SPECT PET reconstruction, where we're using the PET information with the same molecule to guide the SPECT reconstructions. And he's used an algorithm that's been implemented in the STIR package, which is a software, free software, open source software that's available. You can see the link at the bottom of the slide here. And this is called the hybrid kernelized expectation maximization algorithm. So we're going to use this copper-64 image as a guide, as a prior, to help guide the copper-67 reconstruction. So this is going to hopefully address the partial volume correction. And this is really the first time this has been done. This paper was just published a month or so ago. We're now looking at how we can use this to improve dosimetry. And just an example, here's the NEMA NU2 IEC phantom, the body phantom. This is the PET image of that, resampled to the SPECT dimensions, just to show you what you should get if you had a high-resolution SPECT image. And this is what we typically get in SPECT. You can see that the concentrations are very much underestimated to the point where you can't really see the smaller sphere here. And some different reconstructions, OSEM, the typical one that we would use with a few iterations. If you keep pushing that with resolution recovery built in, or resolution modeling, RM, you can start to get some better recovery, but at the cost of increasing noise in the image. And then this is the SPECT reconstruction, or the HKEM algorithm, with the PET guiding the SPECT. Now, of course, there's perfect alignment here, and this is a very idealized situation, but you can see that we're getting some decent recovery. It's the solid line here down to some of the smaller spheres. So I think this is going to be a great benefit and help to us in doing better dosimetry estimates. And we've applied that to some of these patients with meningiomas, and again, an idealized situation where the head is a fairly rigid object, but this is the PET scan with copper 64. There's the lesion there. This is the typical SPECT that we would get. You can see the blurring of the lesion there. And then this is the SPECT reconstruction, greatly improved concentration, and it's starting to approach that of the PET. So this, I think, is a very promising technique to try and help us address better dosimetry estimation based on the actual distribution of the theranostic itself. And this is where gallium-67, I think, can be used also. We can use the gallium-67 to plan, but with these better algorithms, we should be able to get better estimates of the concentration. So look, in conclusion, gallium-67 is readily available radiometal, and it's been around for over 50 years. We know a lot about it, and we've got global supply chains and all that. So we can get it, and it's relatively inexpensive. We are building on the knowledge base from the gallium-68 peptides, the radiolabeling, the chelators, and all the rest of it, and that can be directly translated to gallium-67. So we really don't need to do much work on that at all. The limitations in SPECT performance have been a big issue and are being addressed with both developments in instrumentation and also in the algorithms, such as I've shown you. So what we're going to need is quantitative, good spatial resolution, accurate imaging, and these are the keys to improving personalised treatment in molecular radionuclide therapy. So in retrospect, perhaps we really should have thought of it a bit earlier, but I think gallium-67 does have a lot of promise for the future of developing better approaches to personalised treatments with radionuclides. And if anybody's interested in delving into this a bit more, this article was recently published in the Asia-Oceania Journal of Nuclear Medicine and Biology, and that's publicly available and open source, and you can get that online. Thank you very much, and hopefully